era was comprised of three primary goals that included incentivizing EMR adoption, developing national health information technology or HIT infrastructure through EMR adoption, and reforming the Health Insurance Portability and Accountability Act, or HIPAA. Ultimately, the goal was to bridge the gap between medical care and public health, promoting health for individuals and populations while improving healthcare costs, access, and outcomes. The Health Information Technology for Economic and Clinical Health Act, or HITECH, was part of ERA legislation intended to incentivize EMR adoption and focused on improving privacy and security for health data that would be generated. High-tech changes to HIPAA were necessary to extend privacy protections to data that was intended to be digitally generated and then shared across the care continuum. Some of the new HIPAA protections include the requirement for business associate agreements between provider practices or hospitals and any entity that will have access to protected health information. Additionally, data sharing with patients became a requirement under HITECH by 2013, and many EMRs built in the Blue Button Initiative or other similar secure patient access functionality to meet meaningful use mandates. Healthcare infrastructure born of the EMR push not only provided a central point of access for providers, but standardized care across the care continuum, creating a level of universal standards for care in the United States, according to Schillingstad. In the Health Information Systems (HIS) structure, the database interfaces sit between the EMR or patient database and various other EMR subsystems including laboratory, pharmacy, radiology, order entry or CPOE, clinical decision support or CDSS, patient monitoring, billing, data analysis, research databases, medical dictionaries, knowledge bases, and many others. The interoperability can help streamline workflows, improve quality of care, and assure consistency across the care continuum. The complexity of compiling data from these various sources for a comprehensive patient health record is vast, but it is necessary to culminate valuable healthcare data for the purpose of analysis on various fronts that will improve quality, care, and control costs. A study found that approximately $78 billion a year could be saved through HIE alone. There are other areas where savings could be realized. Providing this level of access can have significant impact on patient outcomes, patient access to care, and cost to treat patients. Reaching the goals of the Triple Aim requires HIE, the use of technology, including advanced technological functionalities such as telemedicine, remote patient monitoring, and sharing of biometrical data. Data sharing helps to avoid duplication of care and medical errors, provides actionable data to researchers, providers, and patients. Patients are exposed to various sources of information on health-related topics like wellness, immunizations, and outbreaks, which may not always be reliable. Patient engagement in our new healthcare system is a vital component of staying healthy, and patient engagement tools like the patient portal, direct secure patient-physician emails, and medically relevant social networking sites like Patients Like Me are all tools being used today. Providing data such as treatment plans, educational materials, and reliable online sources can help patients to better engage with healthcare providers and produces better structured data which can be utilized across the care continuum, including public health research. Various standards we have learned about, such as HL7, DICOM, SNOMED, all play an important role in interoperability of HIE to meet meaningful use, perform quality reporting, and share data for public health surveillance and research. Data derived from these various sources is not just valuable to clinicians, but also to public health researchers and informaticists. Public health seeks to prevent the spread of disease within a population as well as to identify and control outbreaks. This requires monitoring and tracking. Making access to healthcare data from various but disparate sources is a key element for success. Surveillance and research in public health does not only address immediate public health crises, but the etiologic research can lead to treatment recommendations. Public health research results in the detection, prevention, and eradication of disease, as well as contributing to public health policy, improving the health status of population, thus building public confidence. Prior to the availability of EMR and other health data through HIE, gathering data was problematic. The biggest issues were with poor quality of data and just a failure to report, non-reporting, or a lack of understanding. The study found that EMR and health information system technology like lab systems has changed the dynamics of public health reporting, but problems still remain. The lack of information reciprocity between clinical and public health organizations remains problematic. Other improvements include growing HIE infrastructure, continuing to push EMR adoption, training users in the central role of reporting, and moving toward interoperability to converge disparate data sources. Public health reporting is the key to improving the healthcare system, which will ultimately improve the health status of the populations, all while helping to control costs through meaningful care. My public health initiative would be to study the foster care system's impact on child development and outcomes for children as they reach adulthood. I have been engaged in work with nonprofit organization that advocates for families that find themselves entangled in the child welfare system. These families often lack financial resources and have difficulty exiting the complex child welfare systems. Many don't understand that the federal funding tied to foster care is written such that unintended consequences of wrongful removals occurs on a daily basis simply because states need the funds to keep the system going. Most of the allegations are ambiguous allegations of neglect, something that's legally undefined. The study design would be a field function study used to determine the impacts of foster care on the well-being of children into adulthood. Clinical data from insurance claims, EMR records would be used for empirical research to compile data from problem lists, medication, social history, etc. Use of nomenclatures such as ICD-10 and SNOMED would be helpful in patterning the findings. Specifically, we'd be looking for psychological impact and overall health status, including medications. We would also need to conduct interviews of foster care stakeholders, which can include parents, the children, guardian ad litem, social workers, and a slew of other people involved in these cases. Given the broad spectrum of data that would be required for the study, we would use mixed method research to gather the study information. The cohort would be comprised of two groups of children. Group A would be the foster children, and we would seek candidates from jurisdictions where we have high foster care placements, moderate, and then low. Additionally, we would seek non-foster care candidates for Group B from the same geographical area as a comparison. Quantitative and qualitative analysis will occur. Measures from structured data such as ICD-10 and SNOMED codes from data stored in the EMR will be utilized. Statistical analysis to compare findings and make projections for future costs and impacts on public health will be performed. Interviews to gather data and determine other data sources will be necessary. Ideally, an HIE would be invaluable to the study due to the voluminous data that we expect and data coming from disparate sources. Creating a data warehouse as a central point for the study-related data would be helpful for organization, analysis, and data sharing. I expect challenges due to HIPAA and high-tech privacy mandates, which may require legislative support in order to overcome. On any given day, there are approximately 450,000 children in the U.S. foster care system at a daily minimum cost of $45 million a day. What possible chance does the average American have when a state is willing to take a case all the way to the highest courts in the land to get confirmation that they have a constitutional right to lie and commit perjury to take your children?
Are you telling me that a person in your client's shoes couldn't understand you can't commit perjury in a court proceeding in order to take somebody's children away?
Of course not, Your Honor.
Of course not.
Not been presented with any clearly established right that tells us that what our clients did, which is remove the children pursuant to a court order.
No, but what they're accused of doing and what the issue is here is committing perjury in a court to take away someone's children. It's not okay to do.
According to our moral compass and our ethical guidelines, but what we're here to decide is the constitutionality of it.
Based on my experience in the industry, approximately 80% of child removals may be unnecessary. The trauma from those removals is significant for the children and their biological families and will have significant impact on public health and individual health. Failing to deal with the unintended consequences of foster care legislation could have catastrophic impact on future healthcare costs, with these children growing up each year with severe mental health deficits.